We're going to get started. I know that a lot of participants are joining by the Zoom. And, it's a great pleasure to introduce one of the most distinguished alumni of University of Rochester School of Medicine. Dr. Stephen McLeod-Bryan is a clinical associate professor at University of Miami Miller School of Medicine. He is also the president-elect of the Black Psychiatrists of America. He attended University of Rochester as a Wilson Scholar and participated in the innovative Rochester Plan and graduated magna cum laude in cybernetics. Then he went on to medical school also at University of Rochester and completed his psychiatry residency at the Tufts Medical Center in Boston in 1988. He then became a faculty member at the Medical University of South Carolina, where he also had several leadership positions, including vice chair for clinical affairs and medical director of Charleston Memorial Hospital. He also had been the medical director for the South Carolina Department of Mental Health. After 24 years at the Medical University of South Carolina, he moved to the Meharry Medical College in Nashville, Tennessee, and served as the vice chair and also at one point an interim chair for the Department of Psychiatry. In 2015, he joined the faculty of Department of Psychiatry at University of Miami, where he has also served as a co-chair for the Dean's Task Force on Structural Racism, and currently heads the department's Diversity and Inclusion Committee as well. Dr. McLeod-Bryan has been a tremendous leader in our field. He's a life fellow of the American Psychiatric Association, also had been president of South Carolina Psychiatric Association, and also served as the representative for the APA Caucus of Black Psychiatrists for 13 years. Besides receiving many awards, he is a recipient of the APA Solomon Carter Fuller Award, as well as the Gene Spurlock Minority Fellowship Achievement Award. And this year, Dr. McLeod-Bryan is the recipient of the Humanitarian Award by University of Rochester School of Medicine Alumni Council. And this award recognizes alumnus of the school who has provided unique, compassionate care of patients who have special needs because of specific afflictions, poverty, or living conditions that lack resources. And it also recognizes dedication to providing medical care to the underprivileged and underserved. And we are very proud to welcome Stephen to our podium. So please give him a welcome.
Thank you, Dr. Lee. I bring you greetings from wet and windy Miami. I just ask that you keep our neighbors to the west in Tampa and Central Florida and Orlando in your thoughts and prayers. They're going to have a very difficult next 24 hours. What I'm going to be talking with you about is a culture of recovery. What I hope to do, well, first let me give you, I'm not sure what's, okay, there we go, culture of recovery. Wrong button. First, just a disclosure, I have a minor stock position in Pfizer Incorporated, but it will have no impact on the presentation that I'm about to give to you this morning or this afternoon. What I hope to do is to give you a conceptual framework for understanding how recovery from serious and persistent mental illness is possible, and then share with you the way that impact of culture and one's cultural identity, how that plays a fundamental role in the recovery from serious and persistent mental illness, and then observe ways in which cultural assets can be brought to bear to help those with serious and persistent mental illness recover. I come to this topic as a clinician educator who has spent more than 30 plus years in psychiatry, though I have spent much of my time in administrative positions, as Dr. Lee told you, but fundamentally, I'm a clinician, and my interest has always been with helping those with serious and persistent mental illness. I think I came to that interest through a sense of affinity with the struggles that they have in becoming whole people. Much of the way that I felt the struggles of becoming a psychiatrist, a Black psychiatrist growing up in upstate New York, and being the only Black medical student sitting in a room like this here at Rochester, interested in psychiatry. And I think those struggles of becoming myself and becoming whole and in the career that I now love, I saw those same struggles in the people with serious and persistent mental illness. Now, I think I'd like to begin in a way with a sense of the definitions of what we're talking about when I'm referring to individuals with serious and persistent mental illness and the notion of recovery. And I'll use this particular paper that was presented in Psychiatric Services in 2018. Seltzer et al. Presented information from a survey, a national survey that was done of adults in the United States between the ages of 20 and 65 years of age. And in that survey, they asked those adults if they had ever had the diagnosis of unipolar major depression, bipolar disorder or manic depressive illness, schizophrenia, schizoaffective illness, and whether that diagnosis, they were aware of that diagnosis and identified it as being a diagnosis of their own. If they answered yes to that question, they were asked additional questions. They were asked if, because of that diagnosis, they had been hospitalized psychiatrically in the past. And then also they were asked if that diagnosis was associated with significant impairment in function, whether that be function in family, school, work, self-care, et cetera. And if they answered yes to all three questions, having the diagnosis, being hospitalized, and having significant impairment, they were then by definition identified as having a serious and persistent mental illness. What they found in that survey of 41,000 adults is that roughly 6% of those adults were self-identified as having a serious and persistent mental illness. This is quite similar to more recent data that was presented through the survey of drug use and health that SAMHSA presented data from in 2020, in which essentially the same percentage of individuals were identified as having serious and persistent mental illness by the SAMHSA's definitions. So I think the survey is representative of the population that I'm speaking of. More importantly, though, in that survey, in the 2018 survey presented in Psychiatric Services, individuals were asked during the previous year if they had had a period of a year or more without impairment, despite having the diagnosis, despite having previous hospitalization, and despite having significant impairment in the past. During that past year, did they feel that they were free of significant impairment? And a third of those individuals who identified as having serious and persistent mental illness said that they were without impairment. And I would suggest to you that at least by their definition, these would be the folks who have recovered, at least temporarily, from their serious and persistent mental illness. Now, how is this recovery possible? How can we facilitate it as clinicians? I'm going to refer quite a bit to the work of Dr. William Anthony, who was a psychologist who sort of led the charge in the early 90s when I was fresh out of residency and beginning my career as a psychiatrist, who led the charge in this notion of recovery being possible for serious and persistent mental illnesses. Dr. Anthony created the first sort of center for psychosocial rehabilitation and began to build that as a field in Boston back in the late 80s, early 90s. And a seminal paper that appeared in Psychosocial Rehabilitation, Dr. Anthony presented his perspective on the notion of recovery. And importantly, he suggested that beyond just symptom relief, that if a person is truly to recover and gain their sort of personhood and become functioning in this society, that they needed more than just symptom relief. They needed personal safety, access to services to help support their recovery. They needed assistance with their role functioning, self-development, equal opportunity, and empowerment. And he identified services that he felt would be best associated with helping these particular needs be met. He used the model of other organic or medical illnesses that we typically consider in terms of recoveries. For example, when somebody has a myocardial infarction, we talk about their recovery and identify that as something that's achievable. Or if somebody has remission from cancer, we talk about their recovery. That sort of concept and that term was not as familiar when it came to talking about people with serious and persistent mental illnesses. And he uses, for example, the person with paraplegia can recover even though their spinal cord still has significant injury. And he felt that a person with mental illness can recover even though the illness is not cured. He posited that there were dimensions of recovery, that if we paid attention to these different dimensions, could assist in helping meet the needs of the person with serious and persistent mental illness. And one way of sort of illustrating these dimensions is thinking about a student who might have their first episode of psychosis. That student will have perhaps positive symptoms of psychosis, delusions and hallucinations. That's their impairment. That's the abnormality in their thought or behavior that is leading to the diagnosis. But that impairment then leads to dysfunction, their inability to fully focus in the classroom, or their estrangement from their peers and their friends that may support them in their pursuit of a degree. And that dysfunction then leads to a disability, their inability to complete their goals, whether that's good grades in school or to have a mate that they can have a family with and so forth. And then that disability then leads to disadvantage, where they are unable to complete their degree. They may become unemployed, or they may be denied future employment because of the discrimination that is met with their lack of achievement, or with the record of mental health concerns. So with these dimensions, particular services need to be employed to help that person recover. Typically, within my training in particular, the focus was on dealing with the impairment, getting rid of the symptoms, getting rid of the signs of the mental illness. And oftentimes little attention was paid to these other dimensions that would lead to full recovery. And because of the lack of attention to the greater dimensions of recovery, a dynamic tension grew between those of us who are providing care to people with serious persistent mental illness and those individuals who were suffering those illnesses themselves. That tension led to a sense of feeling managed, not being helped, not leading to recovery, and the resistance to this notion of needing a case manager to manage their care. They wanted to achieve, they wanted to grow, to be self-determining. And this tension led to a division between those who were willing to accept the term patient, to then wanting to be known as clients, consumers, or even survivors of the treatment that they had received in the psychiatric system. And this tension and division leads me to now consider how we can help people to recover, how these tensions can be calmed, how the divisions between our attempts to reduce impairment can bridge to leading to full recovery for individuals with serious and persistent mental illness. I'm going to step away from the clinical to talk a little bit about, to just sort of give an example of how culture and recovery can coexist and support one another to talk about a community that recovered, a community that I became very familiar with in my time. Dr. Lee mentioned the fact that I spent some time in South Carolina, 24 years, living in Charleston, South Carolina. Some would call the center of the Deep South. When I left the Northeast after graduating from Tufts and having spent 25 years in upstate New York, I was born and raised in the Binghamton, New York area, and then did 8 years here in Rochester. When I told people that I was going to Charleston, South Carolina, they kind of, gave me the side eye and wondered, you do know that that's the Deep South, and brush that all off and whatnot. And that 24 years there was some of the most important years of my life. Not only did I work at the medical university there and grew a family there and have 3 children, 2 of whom still live in the Charleston area, but I really began to understand what culture was all about. My culture, their culture, our culture. And I want to give the example of how that community survived a significant trauma in 2015 to give you a sense of how culture can support recovery. June 17, 2015, 9 people were gunned down in the Emmanuel AME Church by a lone gunman, Dylan Roof, who came into their Bible study. The individuals were all Black. Dylan Roof was white, but they invited him in to participate. And on June 17th, he killed them all and left. Now, he was arrested soon after that, and on June 19th, 2 days later, at the first sort of bond hearing, individuals, family members of the people who were gunned down were allowed to address Dylan Roof. He was on video in the jail, and the individuals, there were 5 families that were represented, and they spoke to Dylan Roof. And not one of them expressed anger. They all expressed their forgiveness, that they were praying for him, and that they wished that that God would forgive him for what he did. And that made a significant impact around the country. People were incredulous. I got calls and texts from people saying, what the heck is wrong with you people in Charleston, South Carolina? A few days later, on the 21st of June in 2015, there was a number of people that went and marched on the Ravenel Bridge, and I'll show you a picture from that. And then after that, on June 26th, President Obama came to a memorial service at the College of Charleston campus and got together with leadership from the AME Church at the memorial service and began singing a hymn that is well known to the congregations of AME, Amazing Grace, and brought the audience to their feet in remembrance of the folks who died. And over that 9-day period, in the upper right-hand corner is a scene from the march on the bridge, in which people from Charleston got together, all ages, races, faiths, to show their solidarity. And I honestly believe that the culture of Charleston, the history, the beliefs, the religion, that's the Emmanuel AME Church that is pictured there, that those fundamental roots are what helped that community recover in the way that they did. Martin Luther King, who's shown there, this is at a rally that he gave in the 60s in Charleston to the hospital workers strike. There was a major strike in which hospital workers, what was then the Medical College of Charleston, had struck for fair wages, and he spoke there to rally them. Denmark Vesey, who was pictured there, who was a slave who was alleged to have planned the largest slave revolt known in the South in 1822 and was caught and hanged for that crime. He was a member of the Emmanuel AME Church at that time. Those roots, that history, is what held that community together in the way that it did. And I would suggest that it has some lessons for all of us in trying to provide care to those who are trying to overcome serious and persistent mental illness. Ultimately, culture is the sum total of the ways in which a group of human beings have come together to try to deal with biological and psychosocial needs. In Charleston, the history of enslavement, the history of dealing with hurricanes, the history of religion and so forth, all those sorts of ways have come together to form values, norms, beliefs, and attitudes that have linked together people to preserve the society as best they can. One of the ways of thinking of culture very simply is that every culture has a set of institutions or structures which serve particular purposes in preserving the values, attitudes, and behaviors of the people that subscribe to that culture. And every individual within that culture will subsume those particular values, attitudes, and behaviors and create their own identity within that culture. And when it comes to those with serious and persistent mental illness, as it relates to us as clinicians, there is, of course, a certain separation that will be there. I am a psychiatrist. I have a certain set of facts, knowledge, a language that I speak with that sort of separates me from those individuals who don't know the same sorts of facts, the same sorts of knowledge, the sort of the jargon that I might use. But even beyond that, there's a certain separation that occurs because of the power that I have to take away their rights, for instance, if I think that they are dangerous or if they are a threat to themselves or to other people. That's a power that separates us. There's a separation that occurs because of the fact that I can prescribe, whereas in order for them to get medications legally, they have to basically go through me. And that separation is in part my dominance, my power over them as individuals trying to gain the things that they need and their disadvantage. In order to bridge that gap, I would suggest that it's important to keep in mind that what makes us separate with regards to culture are based on the things that we hold as our enduring nature, are the qualities that, whether it's the color of the skin or the religion, our sexuality, our education, the things that have lived with us for a period of time. Oftentimes these differences are shaped by social convention. The fact that I identify myself as Black or African-American oftentimes is led by the context of what's going on socially, politically. It's also important to keep in mind that much of what I hold as being part of my cultural identity is something that I may not think of in certain contexts. So for example, I'm not considering the fact that I'm primarily an English speaker in this setting because I am assuming that I'm amongst primarily English speakers. But when I go back to Miami, I'm reminded every day of the fact that I'm coming from a different culture, as 2/3 of the community is primarily Spanish speaking and not English speaking. Those things come and go with the context and the consequences of what I perceive may occur if I express myself or don't express myself in certain ways. Which leads me to say that cultural identity is dynamic. And that is one of the most important fundamental things that we can take to the clinical situation when we're working with someone who has serious and persistent mental illness. They may be in this box of having the diagnosis of schizophrenia or being disabled or being out of work or what have you. But that identity does not have to continue in that way. It does not have to be permanent. Just as my identity as a psychiatrist who may be unthinking, unfeeling, wanting to put this person away in the hospital so I don't have to think about them anymore, that doesn't have to be me for the rest of my clinical intervention with them. So if we return to how do we bridge this gap, understanding that we're talking about a dynamic, fluid dyad between I as a clinician and the patient with serious and persistent mental illness. It begins with our communication and our language. For all the psychiatrists, psychologists, social workers, whatever your primary clinical role might be, our primary tool is our language, our ability to listen, to talk, to communicate. And I would suggest to you that a very early model, this is so old, this is, I'm dating myself here, but I learned this a long time ago, the LEARN model of how to bridge that cultural gap. Very simply put, listening to the patient's perception of the problems, explaining your perception of the problems, acknowledging and discussing the differences and similarities, recommending treatment and negotiating agreement. That model that was ago still applies today in terms of how to begin to address the cultural differences and perhaps identifying cultural assets that can help the recovery along. Let me just say that there's a much more detailed formulation for how to do this sort of interview. The cultural formulation interview specifically identified in the Diagnostic Statistical Manual 5 as an appendix, and there's now a handbook out that has over 300 pages that goes through the detailed questions that if you really want to get very specific as to the similarities and differences between our clinical perspective and a person's cultural perspective as to what is causing them distress mentally. There's 16 basic questions that you can go through, but I think it all begins with just very active listening to the patient's perception of the problems. And that active listening doesn't just identify what the patient says they think is wrong with them. It identifies where they got that conception from. It identifies, who may have provided that information to them. How did they come up with this formulation for their own perception of their problems? That active listening is not just satisfied with just saying, I'm feeling blue. I still remember to this day when I first went to Charleston, coming from Tufts New England Medical Center, and being placed in a mental health center in Charleston. And this was soon after Hurricane Hugo, because my first hurricane season in Charleston was spent after Hurricane Hugo, Category 3 storm that came up the Charleston Harbor. So that was an eye-opening experience for me. But in that setting, I'm thinking that, here I am, I'm coming from Boston, one of the centers, the great learning centers for psychiatric knowledge, and, having my white coat on, and, I know what's going on much better than the yokels here, right? And speaking with an African-American woman who was telling me about her nerve problem. And rather than listening to her and her explanation of her nerve problem, I went through my structured interview and identified that she was having insomnia, and she was not eating well, and she was having crying spells for no obvious reason, and she was feeling energetic and so forth. And I'm ticking off the boxes, and, ding, 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 5 out of 9 SIGI caps, major depression, clear. And she again would refer, can you help me with my nerve problem? And I, in all my Boston wisdom, said, ma'am, I'm sorry, you don't have a nerve problem. You have major depression. And immediately saw her face turn and give me the side eye. As I was missing, I disconnected. If I just listened to her and just utilized her perception, acknowledged that I have a different idea, but I think your nerve problem is similar to something that I can help you with, as opposed to telling her, no, you're wrong. You have depression. You need antidepressants, which she told me that she didn't want to get addicted to my medication. And I lost a potential opportunity to help her recover. Now, I'm not saying that she didn't recover in her own way, perhaps, but I didn't help. And what I'm suggesting is that's something that if we keep that in mind, if we have that humility to realize that somebody else's perceptions are significant, they're important, and if we work together and acknowledge what's different and what's similar, that we can come to an agreement that can help move the process along. So in many ways, returning to Dr. Anthony's matrix of the dimensions of recovery, when we look at some of these services to the right of the matrix, we're looking at things that can provide self-help, help to people that they can take advantage of on their own without them coming to our clinical half hour or hour to get our advice. I'm going to refer to a story that is posted on a website that I'll share with you a little bit later in the presentation. But Oryx Cohen is the technical assistance director for the National Empowerment Center, and he is someone who has identified himself as having bipolar disorder. And he talks about his recovery from bipolar disorder. And he makes note of some of the things that I've been talking about today in terms of what's important in terms of his recovery. He talks about the support that he had from his family, who had open minds, and he challenged the medical model. In his particular case, when he was first diagnosed as having mania, he was given a fairly high dose. From my point of view, I wouldn't consider it necessarily toxic, depending on his weight, but he was given 2 grams of divalproex as an anti-manic agent, which is a fairly common approach to treating mania, but he had significant side effects to it, and he became very sort of discouraged by the treatment, tried to get other psychiatrists to either take him off of it or reduce the dose, and had a difficult time. And when he refers to his family supporting his ideas of challenging the medical model, that's what he found helpful. He also had friends that he found were helpful in discussing his issues. But the other important thing that he talked about was having a society. And in his case, he described how he found some support in looking at Native American and South American Indian societies that used the sort of the euphoric, ecstatic experiences that he experienced, and saw them as not being necessarily pathologic, but as ways of gaining transcendent knowledge. And he suggested that if our society was a bit more open to considering that temporary experiences like that could be actually helpful or sought after, that perhaps that would have helped his recovery as well. He found that his research in that area was helpful for him. So in that particular regard, I wanted to share some resources here that are present within, the New York State that are available to help people recover, that are part of the culture. One is, Rochester NAMI, very helpful for identifying support groups for individuals, particularly if they're finding themselves estranged from family. I know in Miami, we have a significant homeless population, and oftentimes being able to connect them with support resources can be very helpful in building up their sense of support and not being alone. Very much more difficult now during the pandemic in particular. Some of these support resources are now having more in-person settings where people can go to, but it was a particularly difficult time during the pandemic to try to get them linked into some of the online support resources. Another important area that was identified by Dr. Anthony and is critically important in terms of fighting against the discrimination that many who have serious and persistent mental illness may confront in their attempts to gain employment or continue their schooling, is their rights. And organizations such as Disability Rights New York, every state has these sorts of rights and advocacy organizations to try to support the rights of those who have serious and persistent mental illness are available. And I recommend that you take a look at those resources as they may be of assistance to your patients. And then finally, I mentioned the website where I got Horace Cohen's words about his recovery, the National Empowerment Center. This is a site that was created by Daniel Fisher. Daniel Fisher is a psychiatrist, self-identified as having been diagnosed with schizophrenia when he was an undergraduate at Princeton. He overcame the diagnosis and went on to medical school and did a residency at Harvard. And he created this website for empowerment. One of the interesting things about this website is it gives sort of voice and power to those who, particularly those who feel that they've been violated by the system, and in that the site provides resources for alternatives to the standard sort of psychiatric medication and all that sort of thing, or how to deal with their psychiatrist and related to medication or their rights being taken, provides resources for alternatives, perspectives to treatment. So, I can't say that everything on the site I necessarily agree with, but I do think it's an important resource for individuals looking for all options in terms of gaining their recovery. Finally, something that Dr. Anthony did not really address, although his polemic, if you will, was trying to get the culture of psychiatry to sort of change its approach to how to help people with serious and persistent mental illness. But it's sort of the larger question of how to get society to change, how to get American culture to change, to be more accepting, to be more supportive of those with serious and persistent mental illness. And that's where we get to sort of social change beyond just the treatment or the politics of it. And there's an initiative that is essentially it's being launched next month. There's been a lot of activity and preparation for this major meeting that's happening out in Utah. It's called the Grand Challenge to Eliminate Mental Health and Substance Use Disorder Stigma. It is funded by a large grant that was made by an individual, and it's going through the Huntsman Mental Health Institute at the University of Utah, where they're trying to bring together essentially everyone. That is people with mental illness, providers, many of the organizations like the American Psychological Association, American Psychiatric Association, and so forth have a long list of sort of co-sponsors or partners. And they're going to come together to try to talk about how to achieve social change. It's based on a model that was published by Christina Economos, I believe is her name, in which she, back in the early 2000s, created a movement to try to change juvenile obesity and trying to, looking at how is it that we now put on a seatbelt in cars without any question. Everyone does it, but at one point, many cars, I remember growing up in the 60s and driving across the country with my parents, rolling around in the back seat of a station wagon with my brother, and nobody was seatbelts was unheard of, but somehow there was a change that occurred that made it just a sea change that changed everything for the better. they want to try to do the same sort of thing to create a social change, which eliminates the stigma that holds back so many with serious and persistent mental illness. A caveat, obviously I've been talking about people recovering and achieving their full potential as individuals, gaining rights, being able to function perhaps independently, despite their previous labels of being seriously and persistently mentally ill. However, keeping in mind, again, the cultural notion of what this means, the goal of being empowered, of being independent and so forth is it's a Western goal. Being, out there, having a family, living outside of the nuclear family home and so forth. And it's not for everybody. Acting one's self-interest for some with serious and persistent mental illness, it can be destabilizing, that they require in their particular circumstances, they may desire in their particular circumstances to be at home, to be cared for by others, to not be independently gainfully employed and so forth. And so we have to keep that in mind, again, by reaching out and communicating and listening actively to what it is that the person seeks for themselves. It's important to keep in mind that many of our serious and persistent mental illnesses have different trajectories in different cultures. For example, schizophrenia is known as having a very different course in other cultures, in more agrarian societies. Typically functioning is there's less decrement in terms of their decline, if there is such. The illnesses tend to be more acute and relapsing as opposed to just sort of chronic and degenerating. And then in many cultures, for example, mindfulness practices, which are typically considered more Eastern sorts of ways of living and recovering, that those are the assets that oftentimes for those in our Western societies can be brought to bear to help with the recovery from serious and persistent mental illness. Gary Larson is an old friend of mine. Many of you probably don't know much about Gary Larson and his art, but his humor was helpful in making some points very clear. As we come into this notion of trying to bridge and ascertain one's cultural assets and trying to bring cultural assets to bear, it's important to keep in mind that we have biases, cultural biases that may block our particular vision and may block what we're hearing in terms of what our patients are telling us. This artist who's drawing a fly eye on this woman is not understanding that he has a fly on his glass, his bias that causes him to draw and to see the woman in the way that he does. We also have similar sorts of specs, and it takes introspection to be aware of what those blind spots are. So let me just close by saying that I hope that over this past hour, I've made clear that recovery from serious and persistent mental illness is not only possible, but it is something that requires attention to many different dimensions of a person's needs. It goes beyond just getting rid of the delusions and hallucinations. I believe that one's cultural identity serves as a foundation for recovery from mental illness, not only as it relates to we as providers to that person, but that person's cultural identity itself gives us important clues as to how we can address their recovery. Learning the cultural identity of the person with mental illness provides us access to intra, and we can identify extracultural resources which can promote their recovery. There's some references that are on the slides. I've sent them to department, if anyone is interested, you can ask folks there. And it's been my pleasure to share my thoughts with you this afternoon.
Thank you. That's just wonderful talk. And right now there's about more than 100 people on Zoom line, and I guess we're going to be opening up for Q&A. Anyone from the audience or on the Zoom who has questions? Okay, Catherine.
So thinking about the crossroads between classic adolescent dilemmas, right? Autonomy versus kind of the close parental control that we may want to give to certain kids who are vulnerable. I'm curious if you have thoughts about how empowerment or our concerns regarding empowerment might change across the developmental timeline from kids through our geriatric patients.
Okay, so if I understand your question correctly, sort of thinking about empowerment and recovery from a developmental perspective, from childhood to geriatrics, and I think that's clearly part of that identifying culturally where a person is that depending on the age, the developmental stage of the child, that will determine to a certain extent our approach to that particular, individual. And I think that does have significant interaction. And within a particular adolescent, their push to be free of the family, that will determine to a certain extent what you can do or what you should do in terms of helping them or not helping them to achieve whatever freedom it is that they want to achieve. That clearly is a important consideration, that a middle-aged adult and their particular needs for their family is very much different than, say, what would be for a latent age child. So yeah, it's an important consideration. So I don't have anything specific other than just to be attuned to the developmental stage of the child wherever they're at.
There are a few requests for your slides, and I'll let them know that slides will be available to them as they make the request through the Q&A line. And there is another question. Oh, sorry. Yeah.
My question is about something starting about your own development, and I professional identity as a Black psychiatrist, and how that frames your curiosity towards what a culture recovery looks like for individuals. And some of this has to do with sort of our own various cultural development and whether or not it leads us to be more attuned to those power dynamics within our engagement with patients. And I'm wondering if you could speak to just elaborate a bit more on that, what it was for you, in some of that personal professional development that created that curiosity, and if there are ways that we can amplify that, especially for trainees, to help them what that power dynamic looks like as they're engaging with patients.
Okay. So let me talk about the professional development, because I actually I've had some time to think about that. I'm getting kind of long in the tooth, as they say, and so part of the developmental stage that I'm at is sort of reflecting and sort of seeing, have I really done all that I had meant to do? And part of that is, why the heck did I become a psychiatrist in the first place. And I realized that a lot of it had to do with my upbringing in upstate New York. I mentioned to you that I was born and raised in the Binghamton, New York area. I was actually raised in a community called Vestal Center. Anybody familiar with Vestal? Okay. So Vestal Center, at the time that I grew up, this was, I was born in 1958, okay? And where my family actually had a little home was in a tract called South Vestal, and it was a little circular tract of homes. And I grew up as in the only Black family in that little community, and just about every home had kids. And then they were my age, my brothers and I age, and I grew up in this neighborhood with a bunch of kids, and it was wonderful. I had a great time. We were in the woods, we were playing, we were in the creek, we were splashing around, we would toboggan down the hill in the wintertime. But my mother would always be asking me, how was my day? And I would tell her about the interactions with the kids, and she would be asking me questions about, what did he say or what did she say? And I would say that, they were nice, and they were, how nice were they? And sort of keep asking questions. And I would get kind of irritated. They were nice, they were good. And what I didn't realize until later, she was born and raised in Alabama. And her husband, my father, brought her to this area because he was hired out of Howard as an electrical engineer for IBM. And IBM was doing affirmative action before affirmative action was even a term. And bringing this Alabama woman who was very much used to Jim Crow and, what was happening in the South to this new area that was completely white, seemingly nice, but she didn't trust it. My dad didn't trust it. And so they were questioning, and they didn't want to completely get me paranoid or anything like that, right? Or my brother paranoid. But I began to question. And that's what kind of led me to be sort of listening, to not just accept the first thing that I hear as being the complete truth, that there's always something behind it. Not necessarily bad, but there's more to be learned. And so I developed this sort of listening and not really talking as much. And as I went through different experiences, I found that coming here to Rochester, University of Rochester, I thought I would be interested in internal medicine or family medicine. But there was a teacher here, Otto Thaler, who was a Viennese psychoanalyst who taught about the introduction to psychiatry. And the questions that he was asking and the tapes that he would bring, he had little cassette tapes that he would present. He didn't have, we didn't have these fancy videotapes, but he had cassette tapes of analytic sessions. And the questions and listening to people talk and trying to interpret what was going on was like, yeah, that's me. And so that's what sort of led me to go into psychiatry. And then that questioning and being a part of a larger society in which I was not well represented, at least superficially, led me to sort of consider the differences in perspective and some of the differences in experiences that my colleagues were sharing with mine, and always being sort of sensitive to the fact that I didn't know it all, but they certainly didn't know it all either, and trying to bring that perspective wherever I went. Like I said, I had an affinity for those in mental illness who were suffering, not so much the worried well, so to speak, but the people who were struggling to identify themselves and to be a part of society, much as my experience was trying to assert myself. Now, how to amplify that for students, I think, is just by sharing our stories and hoping that we can ignite some interest just through the sharing of these experiences that others may not have had as much of, but just sort of sharing how unique all of our experiences are, and that there's something to be learned from each one of us. Yeah.
Trying to juggle this. But any other question from anyone? I have a quick question.
Yes.
There's this, I always find bridging the cultural difference between the patient and as a clinician always at times challenging. And there's this idea in cross-cultural psychiatry that perhaps it's a good thing to match the background of the patient and the provider. I was wondering how you think about that. I mean, sometimes we do create like a deaf wellness clinic or Lazarus clinic where we match the language. But should it go beyond that in relation to?
So I think the efforts to try to match the clinician's sort of cultural background to that of the patient is the ideal. That if an individual who has a mental illness is working with someone who comes from the same cultural background, there's going to be a certain understanding, a certain communication that's going to occur that will ease the recovery significantly. However, that match is never perfect. And given our current circumstances today, in which those coming from a disadvantaged culture, however you identify that disadvantage, are in the minority because of their disadvantage. Waiting to have that perfect match could be, very deleterious to the person who's experiencing the mental illness. And so I think the goal as institutions should be to try to have that match, but by the same token, it's incumbent upon all of us to try to be as open and willing to try to learn more about another's cultural identity so that we can make that communication as best we can. So for instance, in an interaction in which there may not be a good match, or there may be a division, and in which case we notice that perhaps the person has become offended or become irritated, or there's something going on that we're not intending, but they're responding to us negatively, is to reach out and say, I'm sorry, you look as if I've upset you. Did I say something wrong? To reach out and try to learn to see if we can bridge as much of that gap as possible, as quickly as possible, and not to sever the ties permanently with that individual who may be different.
Any other questions? I think there's one question, but I'd probably ask him more personally instead, and then get back to the questioner. It's a very specific question. And if there's no other question, we'll end this today's grand. Oh, yeah, Joy.
Just a quick piggyback off of Dr. Lee's question. I've actually had a sort of like opposite experience where patients specifically wanted to seek out a Korean American psychiatrist. And in my visit, the phrase, well, came up so many times. And sometimes I find that that's almost harder to navigate, where the patient almost assumes that you would have had a very similar life experiences by virtue of coming from a similar cultural background, and how to have a conversation around that that's productive, where you do want to maintain that alliance from coming from a similar background, but also recognizing that there is individual difference without, rupturing that rapport that's coming naturally as coming from a similar background. Like, how do you navigate that?
So that's a notion that perhaps is not so much a a cultural one is just, speaking about transference and countertransference, that, just because there is a match or there appears to be a match, a patients will assume more than what is actually true. And the fact of the matter is that just as they may say, well, without explaining, you have to basically say, well, no, I don't know. What do you mean I know? What, in a sense, asking them what they think or what they assume they know about you, or what they think is so similar that they don't, that you are a mind reader, essentially. And so I think that it is something that a patient may slip into, feeling like, oh, I've got the perfect match, therefore I don't have to go through all this this history with you. You understand implicitly, when in fact you don't. A similar sort of circumstance occurs when it comes to, the color of my skin. I get many requests, people who are searching to seek out my treatment because I'm a Black male psychiatrist, and they believe that, there's no other person can help them out besides a Black male psychiatrist. I wish I had the time to treat everyone who wished to have a Black male psychiatrist. But even those folks who come to me, particularly when I was in Charleston, they would say, well, the racism, and I had to tell them, I learned over the 24 years, no, I don't know what it's like to grow up Black in Charleston. I've got some ideas, I've had my eyes opened, but tell me what your experience was like, because I'm originally from upstate New York. And some of that is some self-disclosure to help them understand that you're from two different places, even though you share many similarities.
Great. Well, thank you so much for the enlightening talk, and
All
we'll end today's grand round. Thank you.
All right,
Thank you
you.
again.